speaker in our clinical application segment will be Dr. Gudela Mohan, who is joining us from India Institute of Medical Sciences. He will discuss the utility of transcranial color-coded duplex sonography during CPR for real-time cerebrovascular assessment. Thank you so much for joining us today.
Thank you, Dr. Esman, for the introduction. And I feel honored to be part of this symposium. And I thank Dr. Aarti and Dr. Yesaman, both of you, for the invitation. So I would be talking about transcranial color-coded duplex sonography during cardiopulmonary resuscitation. And so I don't have any relevant disclosures for this presentation. And we all know that during cardiac arrest, two things are pivotal for achieving a good neurological outcome as well as return of spontaneous circulation. And those two key things are, one is prompt initiation of high quality chest compressions as well as early defibrillation. Now, along with these two interventions, another thing has gaining traction, which is point of care ultrasound during cardiopulmonary resuscitation. So the three main objectives of using a point of care ultrasound during cardiopulmonary resuscitation is that, one, it helps us to identify the reversible causes of cardiac arrest. Two, it helps us to understand how efficacious is the chest compressions. Three is that it can be used as an alternative for pulse check to look for return of spontaneous circulation. Now, in this clinical scenario, where does transcranial color-coded duplex sonography stand? So TCCD, by virtue of its ability to look at cerebral hemodynamics, theoretically can help us to look at the efficacy of chest compressions, and it can help us as an alternative for pulse check when return of spontaneous circulation happens. Now, with this, I would like to share our first experience using transcranial color-coded duplex sonography during CPR. So we had in the last year we had a 20-year-old female admitted to our ICU with severe diabetic ketoacidosis, and she recovered from diabetic ketoacidosis, but then she had a secondary clinical deterioration because of the septic shock. Now we were looking at point of care ultrasound to find out the reason for her clinical deterioration and hypotension. At the same time, the patient had a pulseless electrical activity. Our team has quickly initiated a high quality chest compressions, and what I felt at that point of time is, okay, I'm done with looking at the cause of hypotension. Probably that answers my question for what could be the reason for pulseless electrical activity. It could be probably a severe vasoplegia. Now, what I did was I was just curious about how spectral waveforms look like when I do a transcranial color-coded duplex sonography during CPR. So with that curiosity, instinctively I moved to the head end and I started doing this TCCD. Using a phased array probe at the transtemporal window, and I was insufflating the middle cerebral artery. So what did we get? So here is the B mode imaging, where you can see that the chest compressions can be visualized. The chest compressions are being transferred, and we can appreciate in the B mode image. At the same time, what we can also see is that the color Doppler signals of MCA and the distal PCA. So with this, what we did was we have done a pulse wave Doppler and tried to look at the spectral waveforms, and we were able to get the spectral waveforms. What does it show is that all the waveforms had a peak systolic velocities. And when it comes to diastolic velocities, some had a good diastolic velocity, some had a reversal of diastolic velocity. And, as you can see, most of them had some diastolic velocities above the baseline. So, 20 minutes into, cardiopulmonary resuscitation, and we have achieved a return of spontaneous circulation. And that we were able to record as a, hyperemia response, where the peak systolic velocities are very high as well as the end diastolic velocities. So with this, we were quite happy and enthusiastic that we were able to record the spectral waveforms during TCCD while CPR is being going on. So we started looking at the literature, as in whether there was any literature on this particular segment. So then what we found is that there is a limited literature with regards to transcranial Doppler in during cardiopulmonary resuscitation. Out of the literature we got, most of them were case reports, and now I would like to share two case reports which are essential for the discussion. So one is by Lu et al., and this case report was in 1990, published in 1990. So what Lu and team did was, in the emergency department, they have done a traditional transcranial Doppler analysis during cardiopulmonary resuscitation. So the key points from this particular case report is that one, the transtemporal window is extremely not at all useful. One. Second is that during CPR, they were able to get peak systolic velocities, but not diastolic velocities. Three is that, as the resuscitation was going on and they were unable to achieve RSC, they've observed that, the cerebral perfusion has deteriorated over a period of time and they were unable to achieve any spectral waveforms. And the fourth point is that, when they have given epinephrine or the sodium bicarbonate, mean flow velocities were augmented. So this essentially says that they were able to record some kind of spectral waveforms during CPR. Second, some interventions are actually helping us to achieve a better flow rates. So with this, we go to the second case report where Bloomstein et al. In 2010, in the setting of cardiac surgery in operating room, they have used a traditional transcranial Doppler with a head frame. Now, during the cardiac surgery, in the off-pump phase, there was a cardiac arrest. And during the CPR, what they found is that, they were able to get the peak systolic velocities. They were not able to get good end diastolic velocities. And now what they have done is they have improved on their chest compressions. And, by improving chest compressions, what they found is they were able to get a good, reliable end diastolic velocity. So now they say that, because we have improved on chest compressions and we have got a reliable end diastolic velocities, this is a hypothesis generating question saying that, if you give a good chest compressions, the end diastolic velocities will be good. So, with this, we go forward and, look at another case from our center where, during CPR, again, we were able to look at the B mode imaging. We are able to get the nice, MCA signal. And, we were able to insonate MCA and we got spectral waveforms. As you can see, these spectral waveforms, all you can see is a peak systolic velocities. All of them peak systolic velocities, not able to appreciate end diastolic velocities in between. So we have optimized chest compressions, maybe in terms of the rate, the depth, changing the, the person who is doing the chest compression. So by doing so, what we have appreciated as well is that we are able to achieve good diastolic flows, as you can see in the second image. And, once, the compressions have been stopped, we can see that there is a steady decline in the velocities in the spectral waveform. So with all these things, what we felt is that, it is doable. And how are we doing it? So we are doing it for the in-hospital cardiac arrest in the ICU. And, the most important prerequisite is that there should be an adequate team for resuscitation, and also an additional member to do point of care ultrasound who is good with the point of care ultrasound. So we use a phased array probe, a TCD preset, a transtemporal window to insonate middle cerebral artery during the chest compressions. So the most important limitation or, the difficulty what people experience is that during chest compressions, it is very difficult to place the probe, on the insulation windows. So what what we are trying to do is that we asked, we were placed between the compressor and the airway. And when we are doing a TCCD at the trans-temporal window, we asked airway, the person who is managing the airway, to do a midline inline stabilization with one hand and try to stabilize the neck. So by this simple maneuver, we were able to achieve a good insonation, and we were able to insonate, middle cerebral artery without much artifacts. So this small trick can help us, in doing this TCCD during CPR in a better way. Also, we have been, adding on doing other point of care ultrasound modalities, like, looking at the subcostal window, subxiphoid windows, to find out reversible causes of cardiac arrest during this pulse check breaks. Now, what we have felt, or what we have thought of this particular modality, all of this would be a hypothesis generating questions. So the first thing is that transcranial color coded duplex sonography, it enables easy localization of middle cerebral artery. And without interrupting the CPR, the major problem with point of care ultrasound during CPR is that they blame point of care ultrasound for a prolonged breaks. So prolonged pulse checks, prolonged breaks, and prolonged interruptions in the CPR. So what we felt is that, okay, without interrupting, we can actually look into, efficacy of chest compressions, and the another question is that, so if we are able to achieve diastolic velocities, it might be a marker of effective CPR. And if we are able to achieve a hyperemic response during cardiopulmonary resuscitation, that could be a marker of return of spontaneous circulation. So with all of these things, what we also felt is that we can actually look at the effectiveness of various interventions that can help us achieve ROSC as well as good neurological outcomes. Like, say, head up CPR versus CPR in the supine position, and manual chest compression versus mechanical chest compressions. So we can test various interventions, looking at its effectiveness and its influence on cerebral hemodynamics, and we can correlate. But then there are also a lot of questions that are unanswered at this point of time. So what is the ease of insonation for other individuals, other trainees, other physicians at the bedside? So should we do only, unilateral window versus bilateral windows? Which one is good? Can we just, go away by doing unilateral windows, or is it actually required to do both the insonation windows? So this is the second question. Third is that, can we use any other window? So at least say that 20% of 20% of the population, we won't be able to access the transtemporal window. So can we look at the other windows, say transorbital or transforaminal? Can we use other windows? And I am really doubtful, in the presence of intracranial pathologies like raised ICP, will this interpretation of utility of transcranial color coded duplex sonography is actually helpful or not? I'm doubtful, and we need to look into it. And how much time we have to insonate these arteries during CPR to get meaningful output? And so suppose, like, we have insonated the arteries, and then, we have got a diastolic velocities. What is the maximum diastolic velocity we can achieve? And can we correlate these diastolic velocities with the diastolic blood pressure and end tidal CO2? Because these two are used as physiological basis to physiological feedback information to improve our chest compressions. And can we correlate with return of spontaneous circulation as well as neurological outcomes? And say that now, because extracorporeal CPR is is also gaining traction. So how does spectral waveform appear, after return of circulation when extracorporeal CPR has been, initiated? So now there are a lot of research gaps, there are a lot of hypothesis generating questions. So with all these things, what we would like to do is, we would like to make a, good protocol on paper. Then we initiate case series. Already we have done, say up to 7 cases we have done. So the case series is a beginning, and we might be able to do observational studies in future, and say that if results are good, maybe why not using transcranial color coded duplex sonography, can we actually improve the outcomes, an RCT maybe. And for all of this to do, I personally feel collaboration is the way to go. Maybe Dr. Zhu's flow patch, wearable TCD devices, or Dr. Deepak Sharma's simulation. With all of this, and in the with all the collaboration on the global platforms, maybe we may do well in this particular niche and develop this particular novel ultrasound technique. So time will tell. Thank you so much, and any questions I'll be happy to take.